Good afternoon. My name is Deborah Miller. I'm the Health Policy Director for the Council of State Governments at our national headquarters in Lexington, Kentucky. I'm pleased to welcome you to our first health webinar of 2012. Today's webinar is entitled Medicaid Managed Care, Asking the Right Questions. We'll be joined in just a few minutes by three individuals who have deep and very different expertise on today's topic. But first, as always in these webinars, a few housekeeping details. All attendees are in listen-only mode for the entirety of the webinar. You will be able to submit your questions at any time by filling out the question box in the GoToMeeting panel that appears on the right-hand side of your screen. We'll hear from all three panelists, and then we'll have time to ask and answer your questions. You'll have time to ask your questions, and we'll have time to answer them. We'll post the PowerPoint presentations and audio from today's webinar on the CSG website and our Knowledge Center. As a participant, we will send you an email link to that posting next week. We'll also publish a summary of the webinar in our e-newsletter, which comes out next week, that we know many of you receive. Medicaid is probably the biggest elephant in any room where policymakers are discussing state budgets, state policy, or health care. NASBO, the National Association of State Budget Officers, reports that Medicaid accounted for 23.6%, nearly a quarter, of all state budget expenditures in fiscal 2011. This share now exceeds primary and secondary education. Policymakers of all stripes are looking for ways to bend the Medicaid cost curve. Managed care is one of the solutions to which many states have turned. Today, we hope to give you information and tools to help you better analyze the success of managed care in your state, both in terms of savings and improved health outcomes for Medicaid members. Kathy Gifford, our first panelist, will provide background information on the status of Medicaid managed care across the state and what to expect in the future. Kathy comes to us from Health Management Associates, a healthcare research and consulting firm. She is the primary author of a report with the Kaiser Family Foundation entitled A Profile of Medicaid Managed Care, Findings from a 50-State Survey, that was released in September of 2011. Before joining HMA in 2002, Ms. Gifford directed the state of Indiana's Medicaid program. At that point, it was a $3 billion program providing care to over 650,000 members. We laughed a little earlier this afternoon saying those numbers are a little out of date. She also has other experiences within state government in Indiana, was responsible for budget development, policy, and fiscal analysis on a wide range of issues, including welfare reform, school funding equalization, and, of course, Medicaid. So we'll turn it over to Kathy here to get us started.
Great. Thanks so much, Deb. I think we'll go to the next slide right off the bat. Good afternoon, everyone. It's a pleasure to join you for today's webinar and share with you some of the results of the recent 50-state survey that Deb referred to that I worked on with my colleagues Vern Smith and Dyke Snipes for Kaiser, the Kaiser Commission on Medicaid and Uninsured, focusing on Medicaid managed care. Now, the survey collected detailed descriptive info as of October 2010 that covered many aspects of states' managed care programs, as well as information on their quality initiatives, managed long-term care programs, managed care for dual eligibles, and expectations for health reform. Next slide. But first, I want to note that states are interested in managed care because at its best, it gives them what fee-for-service delivery systems just can't provide. First and foremost, accountability, particularly to ensure that members have access to the services they need and that the care that they receive is of high quality. Also, managed care contracts provide states a structure they can use to align incentives, especially financial incentives, that then help the states improve quality outcomes and community health performance. Finally, managed care can offer states budget certainty, a little bit of greater budget certainty and the potential for cost savings. Now, can managed care really save money? That's kind of the $64,000 question. Clearly, the volume of new and expanded state managed care procurements planned and underway currently suggests that these states anyway, are betting it will. And in our survey, we did ask that question of state responders and about all the different forms of managed care. And over half of the states for each kind of managed care attributed at least some or significant cost savings to each managed care model. Others indicated that even if cost savings were modest or not realized, managed care offered the state better value over fee-for-service. Next slide. In our, go to the next slide. Right, there we go. Go back one, I'm sorry. The one that says risk-based. Thank you very much. We asked states about the different models of managed care in our report that the federal government recognizes in their managed care regulations, and that is the three on this slide here. The first one is risk-based managed care, which is HMO-style managed care, a comprehensive benefit package with capitated financing arrangement. The next kind is a fee-for-service. Services are still reimbursed on a fee-for-service basis, but in the primary care case management system, the primary care provider receives a small per member per month case management fee to organize and coordinate the care of the member. And finally, the third category are prepaid health plans. There are prepaid ambulatory health plans and prepaid inpatient health plans. These are non-comprehensive and usually capitated, but it would be like if your state decided to have a contract for dental only, that capitate dental services only, or many states have these prepaid health plans for behavioral health. So we asked about those as well. Now we'll go on to the slide with the map. And what we found in 2010, when we looked at the comprehensive forms of managed care, the risk-based managed care and the PCCM, all states, with the exception of 3, had one or the other or both. So only Alaska, New Hampshire, and Wyoming reported that they did not have comprehensive managed care in the form of MCOs or PCCM. As you can see on this map, if you take the time to count up the states there are 19 states that offered both risk-based managed care and PCCM instead of just one or the other. And then, of course, I mentioned those prepaid health plans. Alongside of these comprehensive arrangements, half of the states, about 25, also had contracted on a risk basis for these non-comprehensive types of managed care, these prepaid health plans, for a particular service or set of services like behavioral health or dental care. Clearly, there is great variability among the states in how the various managed care models are employed. Okay, next slide. In our survey, we did try to collect enrollment data as well. CMS collects this data too. Our data was as of October 2010, and based on our results, we found that about 2/3 of all Medicaid enrollees are in one of those comprehensive managed care models, the MCO model or the PCCM model. Half are in MCOs, and 16% are in the PCCM delivery system model. And that leaves just a little over 1/3 of Medicaid enrollees still in traditional fee-for-service delivery systems. Next slide. In our survey, we were also interested in learning more about the profile of plans that served Medicaid beneficiaries. From the survey, we learned that almost 2/3 of Medicaid MCO enrollees are in plans that specialize in Medicaid. That is, that plans that provide care either primarily or exclusively to Medicaid beneficiaries. For-profit plans now account for more than half of all Medicaid beneficiaries enrolled in MCOs, 53%. However, publicly traded plans are not dominant. They account for about 4 in 10 Medicaid MCO enrollees. Finally, MCO enrollment is about evenly distributed between local plans, that is a plan that may just operate in one state, or multi-state or regional regional or national plans, about half and half there. Go to the next slide. Now, I mentioned earlier that about 2/3 of all enrollees were in a comprehensive managed care arrangement. If we look at the CMS data, They report, with just 2 exceptions, over the past 2 decades, we've seen steadily increasing managed care enrollment over those past 2 decades. Again, like I said, with only 2 exceptions. One of those exceptions was the data they just posted, I think it was late October or early November, for showing managed care enrollment as of July 1, 2010, after our report was released. They show that instead of 66%, that only 64% of all Medicaid enrollees were in managed care, which was just a very slight dip, and about, again, 49% in MCOs and 15% in PCCM. However, we're going to get into this next. I think it's my belief that given all of the pending procurements that have either recently completed or about to be completed, states going in, contracting out for managed care, that we will quickly see that this was a short-term blip in the long-term trend, and that those growth trends are probably going to resume the next time CMS publishes their Medicaid enrollment data. So let's go to the next slide. This slide shows the recent huge upsurge in Medicaid managed care, capitated managed care RFP activity. So you can see here, and I've grouped it by the implementation dates of states that have gone out to bid for managed care to be implemented in 2011 or about to be implemented here in 2012. I've tried to hide, now states, obviously a lot of states already have managed care, capitated managed care arrangements, and so sometimes they're rebidding those existing contracts. And when they do that, you can see in some cases I've shown where they are rebidding, but they're also expanding at the same time, which means they might be moving into other geographic areas that weren't part of capitated managed care before, or they're expanding to additional populations. But clearly I've highlighted the huge amount of activity in the large number of states that are doing some kind of expansion of their managed care programs in 2011 and 2012. And you can see a few of them, like Mississippi, this is brand new for them. They didn't have capitated managed care before that. Texas, I think we'll hear more about later, had managed care, but it was rebidding and doing a big expansion, and maybe we'll hear more about that later. Moving on to slide 9, or slide 10, I guess. The next, this is just what some of my colleagues try to keep track of what we know, and the Kansas, that's out in the field right now, so that's going to be, they're going to implement their new rebid and expansion in 2013. We expect, and Pennsylvania's already out in the field, we expect RFPs to be issued by Ohio and Florida and Georgia and Illinois, and I would not be surprised, obviously, as 2012 continues to see more state names added to that list. Let's go to the next slide. As I mentioned earlier, about 2/3 of all Medicaid enrollees are either in an MCO or PCCM arrangement, and only 1/3 in fee-for-service. Now, this data on this slide is a little bit older, but it illustrates that despite that 2/3, 1/3 arrangement, the vast majority of spending, Medicaid spending overall, is still in unmanaged fee-for-service. Next slide. So it's not surprising then that states are increasingly looking to managed care, to use managed care for persons with complex health needs that otherwise drive those fee-for-service expenditures. So children with special health care needs, seniors, and persons with disabilities. 11 states at the time we surveyed had capitated managed long-term care programs that with total enrollment of over 400,000. And a significant number of states had at least some kind of Medicaid managed care arrangement where dual eligibles could enroll on a voluntary or mandatory basis. And of course, dual eligibles are those persons who are eligible for both Medicare and Medicaid. Next slide. I think that is going to be the area to watch over the next couple of years. The Accountable Care Act included a recognition of the poor coordination of care that many dual eligibles currently experience because the Medicare and Medicaid programs are not well aligned. So it addressed this by creating a new federal coordinated health care office whose charge is to improve that integration of care, of the multiple care sources for the dual eligibles, and to work with states on demonstration projects to come up with innovative ways to do that. Let's go to the next slide. So one of the things that they've already done is, as of last April, they awarded 15 state demonstration contracts of $1 million each for states to take on planning activities around developing these integrated care initiatives for dual eligibles. And of course, in that process, what they're looking for is they're looking for scalable ideas, but they also want to make sure that we are coordinating, the states are coordinating all the kinds of care, not just acute care, but also long-term care, not just physical health, but also behavioral health, and of course, coordinating both Medicare and Medicaid. Now, after they awarded those planning grants, they issued new guidance to states in the form of a Dear State Medicaid Director letter, and for states that didn't get the $1 million planning grant, they still, under this letter, have an opportunity to contract with the federal government for a demonstration to integrate care for duals. And in that letter, the federal government provided 2 different models that they wanted to test. And so they asked states to submit letters of intent by October, I think it was mid-October, indicating whether they would be interested in contracting with the feds for a demonstration project around either a capitated integrated model or a fee-for-service integration model. The capitated model would be a 3-way contract between CMS, the state, and the health plan. And the managed fee-for-service model would involve a retrospective payment to the states if there were savings. So in both cases, in both models, there is the potential that if these are successful in actually achieving some savings, that the states will be able to share in those savings, which of course has been one of the huge barriers in the past that has kind of prevented states from making much progress, because historically Medicaid may make investments to improve care, but if you've avoided a hospitalization, for example, that savings accrues to the federal government in the Medicare program. So this is pretty exciting. And if you look on the next slide, you'll see a map showing the 38 states that submitted letters of intent for these dual eligible integrated care initiatives. And by my count, I went through and read them and counted them. There, I found 13 states that had expressed an interest in a capitated model, 9 states that wanted to do managed fee-for-service, 11 states that said both, although one of those states was Vermont, which said we want to do capitated, but if that doesn't work, we want to do fee-for-service. And then 5 states where it was undetermined, they weren't specific. They hadn't decided yet which model they wanted to do. So next slide, I'll close then by just observing that over the outlook for 2012 and beyond is, I believe, for continued expansion of Medicaid managed care, and we should keep our eyes on these dual eligible initiatives in particular to see what states are coming up with for that, as well as down the road even further when healthcare reform is implemented, bringing all those new Medicaid enrollees on. Many of them will go into managed care as well. While this occurs, I think through all these procurements we're seeing, and we will continue to see, a focus and emphasis on quality performance measures and pay-for-performance incentives to align those incentives with our policy objectives. And of course, what presentation on Medicaid is complete without mentioning cost containment. Obviously, lots and lots of emphasis on cost containment. And finally, over the next couple of years, and I know there are court cases and everything that will weigh in on this, but still, as we approach that deadline for the implementation of healthcare reform, we'll see continued policy development about how their Medicaid managed care delivery systems in states are going to interact with and coordinate with healthcare offered through the exchange. And so that is something we'll have to keep our eyes on. And with that, I'll turn it over to our next panelist.
Thank you very much, Kathy. I think that gives us all a common understanding of where the states are in terms of their use of managed care. Our next speaker is Mr. Chuck Ingolia. He'll give us a perspective on Medicaid managed care from the behavioral health viewpoint. In his current role as Vice President of Public Policy for the National Council for Community Behavioral Health Care, Chuck directs federal affairs and provides policy and technical assistance outreach to nearly 2,000 member organizations across the nation. Most recently, his efforts have centered on key issues such as parity, healthcare reform, and increasing access and retention in community behavioral health care. Prior to joining the National Council, Chuck worked for the Federal Center for Mental Health Services at the Substance Abuse and Mental Health Services Administration, where he provided policy and program design guidance, including the review of state Medicaid waiver applications. He has clinical experience working in community organizations and is now an adjunct faculty member at George Washington University and volunteers with local organizations in his hometown. Thank you, Chuck.
Well, thank you for that introduction, and Kathy, thank you for that wonderful overview of state activity related to managed care. We can go immediately to the next slide. I'm going to be talking from the perspective of the National Council, and as the introduction indicated, we are an organization that represents community-based organizations that provide mental health and addiction treatment services. So I'm going to talk a little bit from the perspective of Medicaid beneficiaries who fall into that category, who are disabled because of their mental illness, although I do believe that some of the comments that I will be making are relevant to other people who have disabilities as well. Let me go to the next slide. I think Kathy gave a really good overview of, kind of state interest in managed care, and I think the National Council shares a lot of the values that states are seeking by procuring managed care, and that's accountability and the ability to improve the quality of services offered to populations that are enrolled in Medicaid. And I think what we also want to preserve is the role of Medicaid as a provider of support services to people with disabilities. I think it's very clear that people are on Medicaid for very specific reasons, because of the severity of their disability, their inability because of their disability to hold meaningful employment, and that these people require ongoing support. So part of what we want to talk about is what are managed care approaches that work for this population as compared to what could be problematic. You can go to the next slide, please. As Kathy indicated, many states are currently procuring or expanding Medicaid managed care. And I think what we really want to focus on is what is our experience to date with the various types of managed care, the comprehensive at-risk managed care arrangements versus the more limited or specialty managed care approaches such as behavioral health carve-outs. I think Kathy talked a little bit about the overall number of beneficiaries who were in the different managed care arrangements, and we both relied on that same June 2011 MACPAC report, which showed the distribution of beneficiaries by managed care arrangement. So there already is a fair amount of penetration of specialty managed care across the country, of carve-out or limited benefit plans for people with behavioral health disorders. Not as many beneficiaries with disabilities in comprehensive risk-based managed care programs. And I think that's been by design, because there have been historical concerns about the adequacy of those approaches for meeting the ongoing support needs of that population. And I'm going to try to talk a little bit in the few minutes that I have about what we see as some of the differences, or another way to think about it in the theme of today's webinar, or what are the kind of questions you want to be asking as a decision maker as your state is considering various managed care approaches, and how do these things play out. I would say that in the states that have adopted comprehensive risk-based managed care approaches for people with disability, our experience suggests that those states have had to go in sometimes through the legislature to address deficiencies in that approach, or to provide further guidance to contractors in the forms of addressing criteria for medical necessity determinations, benefit design, or to make managed care contractors at risk for inpatient utilization. So I think those are things that have happened in certain states as they've gone to these approaches. And again, things that I think you want to try to keep in mind. Why don't we go to 2 slides ahead? So again, what I want to then do is try to talk a little bit about the differences between approaches of comprehensive risk-based managed care versus limited benefit approaches, and what are some of the key areas of difference as described on the next slide. And as I mentioned, that the Medicaid beneficiaries, specifically those who have serious mental illness and are therefore disabled because of those illnesses, look very different from mothers and children who are insured by Medicaid. That the very nature of serious mental illness brings with it cognitive impairments, that these illnesses are episodic, so that it's hard to predict when an illness will become severe enough to require more intensive services, that typically people with serious mental illness require ongoing supports to maintain their current level of functioning, and that there are significant costs associated to individuals, communities, and to the Medicaid system when mental illnesses are not treated adequately. And I think what we see then, by looking at the difference between comprehensive or MCO approaches to managed care versus limited benefit designs or carve-outs through managed behavioral health care organizations, are a number of differences in key areas as listed on this slide, and we'll walk through these very quickly. And again, I think we're in the spirit of this webinar, these would be areas that I would suggest you'd want to focus on in RFP design or in evaluation of potential vendors along these issues. And first would be, as described on the next slide, outreach and access. And again, we have to think about the intersection of cognitive impairment as well as mobility for the and there's the nature of these illnesses that would limit people's willingness sometimes even to engage in treatment, that behavioral health providers sometimes have to spend a lot of time out in the community working with individuals with these illnesses to keep them engaged in treatment, and that you would need to have benefits that would be flexible enough to provide that kind of mobile, assertive outreach and engagement with individuals, sometimes pretty intensive, to keep them engaged in treatment. And our field experience has been that this is frequently in-person contact. And I would think about this both in terms of initial engagement in care, as well as, we'll discuss this a little bit later, that these populations also tend to have multiple chronic health conditions as well that require intensive care coordination, and that this usually has to be done in person. That telephonic approaches to care coordination for this population have largely proven to be ineffective. So outreach and access then also touches on who are the contracted providers, and we can go to the next slide, that typically managed behavioral health care organizations have a diverse panel of providers that they're used to working with, including community-based mental health treatment organizations, and that those organizations are typically credentialed as the organization, not as individual providers, allowing for a diverse treatment team running the continuum of physicians to persons in recovery for mental illness themselves to engage in those outreach and engagement activities. So outreach and engagement would be the first area to look at, and then the next slide talks about the range of benefits that would be offered. And again, I think what we want to be thinking about here is what are the particular needs of individuals for ongoing, some occasional intensive supports to preserve functioning. And when we think about what happens when someone becomes psychotic, the two places that they usually end up, unfortunately, are either the emergency room or the county jail. Both of those are very expensive ways to access care. They're expensive in terms of to that individual, to their family, and sometimes to their community to have untreated mental illness. So we would suggest that there be a range of benefits offered in order to maintain that level of functioning. We can go to the 2 slides. And again, in the vein of questions to be asked or areas to investigate when considering procurement, also then the extent to the kind of range of recovery-based and flexible services that many managed behavioral health care organizations are more familiar with, that fall outside of traditional medical plans, but are very common in managed behavioral health care organizations. And as Kathy indicated, many of these limited benefit or carve-out plans can be done on a capitated basis, ensuring accountability, but also then providing provider organizations with the flexibility to provide the right service at the right time to engage that person and maintain their functioning. We can go 2 slides ahead, please. Because of the flexibility in terms of financing and that have been historically utilized in managed behavioral health care approaches, the flexibility in terms of services provided as well as the flexibility in terms of providers enrolled, we have a lot of data showing that this approach of managed behavioral health care organizations does save money as compared to unmanaged fee-for-service and provides a good value for states. Because of the more limited application of comprehensive MCO approaches, we don't have as much data. So it's more, though, a function of there being not as many examples of that. The last slide that I'd like to speak to today deals with a very important issue. I mentioned briefly that people with serious mental illness tend to have multiple comorbid physical health conditions. And what you want to be able to do is to provide comprehensive services that address both of those. And this has manifested itself in the average age of death for a person with serious mental illness being in the mid-50s, that they have significant reduced life expectancy because of these comorbid physical health conditions. And in whatever approach you take, you want to ensure that attention is being paid to integrated approaches that facilitate access both to primary care as well as to behavioral health interventions. In the interest of time, I'm going to stop there. I would note that my slides also contain additional information regarding potential performance measures related to those areas that were outlined, outreach and engagement, benefits, etc., that could be beneficial to decision makers as they consider various approaches.
Okay, thank you very much. I think you did exactly what we had hoped as we were putting this presentation together in terms of giving policymakers things to think about and questions to ask as they consider, as Kathy pointed out, either rebidding or expanding Medicaid managed care in their states. Our last speaker is Representative John Zerwaz. He is, as I called it in my introduction, he's a warrior from the policy trenches. He worked last year in the Texas legislature that was tasked with closing a $27 billion, that's with a B, $27 billion budget shortfall. As part of the solution, the legislature required the state to submit a Medicaid waiver that would, among other things, expand managed care to as many as 3 million Medicaid members. I think we saw that in Kathy's slide. Representative John Zerwaz is a doctor. He represents Texas House District 28, located west of Houston. He served 3 terms in office. In June of 2011, he did, in fact, pass legislation designed to save Texas more than $400 million over the coming biennium to make Medicaid more cost-effective and expand Medicaid managed care. He has twice been named one of the 10 best legislatures by Texas Monthly. In 2011, he also served on the House Appropriations Committee and the conference committee that sets the state biennial budget. He's an anesthesiologist in the greater Houston area and has served both as the president of a network of providers and the chief medical officer of a local hospital. And he'll tell us about his Texas experience.
Well, thank you for the kind introduction, and I really appreciate Kathy and Chuck's presentations. I think they give Chuck's a real challenge for us in terms of mental health and trying to deal with that in a cost-effective way. And Kathy giving you a great overview, I think, of what some of the challenges are in that. We are sort of the poster child of the utilization of managed care in the Medicaid program. And I consider it an honor and a privilege to get to share kind of what some of the background of that is in the state of Texas. I will say it's an ongoing thing to make sure we get it right and don't falter on our delivery of services. So let's go straight to the next slide. This is a slide that really is just meant to sort of depict what has sort of led us into this not experimentation, but really this adoption of managed Medicaid as the way to deliver care in a cost-effective way. If you look at our general revenue spending back in the year 2000, you can see that we spent the majority of it on education. 62% of our general revenue was spent there, and 20% of it was spent in health and human, so it was the second largest at that time. But if you look 10 years later on the slide to the right, you can see there's been a substantial shift. Whereas education was 62%, it's now 56%. And health and human services has gone from 20% to 28%. And so, as you can see, it's becoming an ever-increasing part of our budget. I've had individuals tell me that, in fact, health and human has overcome their education budget. And I will be quite frank in saying that's exactly what we're trying to avoid. I consider education to be the premier responsibility of the state's legislature, and I want our checkbook to reflect that, basically. So that kind of gives you at least a sort of 30,000-foot level as to what were the fiscal issues that we were facing that really sort of took us down this path of Medicaid managed care. So let's flip to the next slide. This is, again, just a graphic depiction of where we've seen the money being spent. It goes all the way back to 1981. And as you can see, the amount of money that the state is spending on this has risen substantially year over year. But what is really the takeaway on this is really the steepness of these curves. And I think that's somewhat of the frightening thing that's associated with this. Most recently, what we recognized, and it primarily came about as, I think, a focus on healthcare reform, but we under-budgeted significantly during our last biennium on the amount of enrollment in the Medicaid program. Typically, we budgeted that at about a 3% increase in enrollment year over year, and we're usually pretty spot on with that. What we were finding during this last biennium was increases of 9, 10, and 11%. And we saw, even without health care reform, the enrollment in it was swelling well beyond what we had budgeted for. And so I think these are things that largely other people are recognizing out there. The pace of spending in health and human services, and specifically the Medicaid program, is far outpacing the ability of our tax revenue to keep up with it. And so, there was a real strong urgency to look at alternative ways to deliver that care that would be cost effective without compromising access and quality of care. We'll go to the next slide. This, again, is probably something similar to other states out there, in that despite the fact our enrollment is dominated by non-disabled children, recognized in our state as 66% on the graph on the left, followed by age and disability related, 25%, your nursing home patients, and then the non-disabled adults being a smaller number. But you look at where we spend the money, and you can see it's in these aged and disabled related individuals. So the smaller group of people account for the largest amount of cost that's in there. And this isn't unique to Medicaid either. This is just typical of what we see out there in other payer groups and so forth. One area, and this is a little bit of a sidebar, but when you look at the Medicare program, the vast majority of the costs caught up in the Medicare program are in that last 6 months of life. And so getting our arms around how we deal with the aged and disabled and the whole end-of-life issue is a very important thing for us to ultimately get a handle on what some of these costs are that are related to the aged and disabled. We'll go to the next slide. This is just saying, where do we spend our Medicaid dollars in terms of services? The next slide will show providers, but in this slide, where you can see is that we spend a lot of money in both hospital, inpatient, and outpatient. There's a variety of supplemental payments that are also come into this whole picture that are depicted by the graph to the right, upper payment limit, disproportionate share, and then various parts of the Medicare program that pay into this. And so substantial amount of supplemental payments that go primarily to the hospitals in terms of keeping up with some of the costs that they incur. Physician and professional services are also baked into that, as you see, around 17%. And then the long-term services and supports are at around 24%. So substantial amount of money that is spent over in the long-term services and support. Next slide. In terms of the provider groups that are paid out here, you can see the hospitals are paid 43% of that. Physicians and nursing facilities come in at 13% each, and then all other providers, which is a large group of other people out there that are paid out of the Medicaid program, comprise 14%. Go to the next slide. So in this last legislative session, which is really characterized by Senate Bill 7 that I have depicted up here, and the rest of my slides will address Senate Bill 7 and the things we looked at. It was really trying to get, not only would we expand Medicaid across the entire state, which there were some areas that were carved out of it, but it would also allow us to look at delivering on things that would reward quality and efficiency as opposed to just pure productivity. Right now, the healthcare system we have and the Medicaid and Medicare system are included in this are designed to give us exactly what they do. They're giving us exactly what they're designed to do, and that is productivity. So the more you do, the more you get paid. There really is very little incentive for healthcare quality and efficiency to be rewarded out there. And so you're seeing a lot of that in federal healthcare reform also, but we looked at doing some things at the Medicaid program that would also look at rewarding these behaviors that would help us rein in the cost of healthcare. First bullet just says there's a few counties there that were legislatively excluded from managed care. We got them included. That was a bit of a political effort to do that, but ultimately that was what allowed us to go statewide with the managed care program. We also carve prescription drugs into the managed care organization plans. Formularies and drug utilization, as you know, is a big part of the rising cost of health care. Carving that into the managed care organizations is something that we felt would probably be helpful in terms of reining in the cost. We also put into place a study of creating physician incentives to reduce non-emergent use of the emergency room and if these were found to be cost effective, and I think clearly they would be, then those recommendations could be implemented during this 2-year biennium that we're in right now. Cost sharing opportunities to improve appropriate program utilization. This just simply means that providers that commit themselves to doing some of the improvements and stuff in terms of cost-effective care could basically enjoy some of the savings. Again, this is creating those incentives that allow people to do things differently than what they did before. It does create a quality-based payment advisory committee, so a group of people that would include physicians that would be looking at ways to improve quality-based incentives and so forth. It also establishes something known as the Texas Institute of Healthcare Quality and Efficiency, this being, again, a group of people that would be looking at those best practices out there that would reward quality and efficiency in the private sector as well as in the public sector. The next slide. Continuing to look at some of the initiatives in Senate Bill 7, it does require the development of quality-based outcomes and process measures. These are things that we've seen a lot out there related even to pre-healthcare reform. Looking at those things that organizations, physicians, providers can hold themselves accountable for, and when they meet those outcomes, they can be rewarded for them, as opposed to, again, just doing things and enhancing a productivity system. They're looking at some of the new quality-based payment systems for managed care, for home health, and for hospitals. So you can see it's not directed at any one group. It's really intended to be transformational in some of the things that we've authorized to be done. Developing alternative healthcare delivery systems that promote healthcare coordination and provider collaboration does establish the healthcare collaborative guidelines and support. This would be akin to the accountable care organizations that are defined in the National Healthcare Reform. Basically, it's intended to create a safe harbor that would allow providers of all groups, physicians, others, and hospitals, to be able to work together to come up with some of the best practices that promote quality and efficiency, and to basically enjoy some of the savings that go into that. And what we're looking at is in our procurement of managed care contracts to look for companies that basically will be incorporating some of these tenets. Next slide. It encourages cost savings by implementing and identifying the following 3 things there. The alternative payment systems, which are episode-based bundle, global payments, and blended payments. Again, these are all things that are further defined in our legislation, but are all intended to try to promote those practices which will reduce some of the costs that are not appropriate for good quality care. Preventable conditions, the second bullet you see there in blue, relates to preventable admissions, preventable ancillary services, complications, readmissions. What I will say is that hospitals and medical staffs across this state have really been pretty involved in doing this. At some point in the past few years, Medicare stopped paying for certain complications, such as ventilator-associated pneumonias. Very quickly, physicians and hospitals have jumped on that and have reduced or have eliminated that as a complication of intensive care now for many consistent months out there. Readmissions, again, these are things that if you do certain basic things, you can prevent readmissions. And these things, if you look collectively at those 4 things, those things can account for millions upon millions of dollars of things that don't need to happen and which obviously aren't in the interest of quality care. And then creating those payment incentives for high-quality, cost-effective care and the utilization of best practices. That, in summary, I don't think that's my last slide, but in summary, those are the things that we basically marshaled in Senate Bill 7 during this last special legislative session that was called, that we think not only does it spread the managed care out there, we know that we're going to get a savings by doing that because we've been doing it for many years over right now. But really creating some transformational initiatives out there that once you're in managed care, how can you manage, quote unquote, manage the care so that you can see, year over year and continued improvements in the quality of care out there. So with that, I'll close. I want to thank you for including me on this panel. I've enjoyed hearing the other speakers and look forward to any of the questions that we might have.
All right. Thank you very much. We've got a few minutes for questions. Please feel free to type them into the question box in the GoToMeeting panel on the right-hand side of the screen. We have a couple of them, and one, since Representative Drawaz just finished, I guess I'll go to the question that's directed toward him, and that is, what were the major arguments that you had to overcome in order to pass Senate Bill 7? I know that's a big question, but if you could just give us a few ideas of what you faced in passing that bill.
That's a great question, and our expansion of Medicaid into the entire state, the largest being in an area that we call the Valley, which is down there towards the tip of Texas that borders Mexico and the Gulf of Mexico down there. That was an area that had been excluded in statute from Medicaid managed care being rolled out. One of the biggest arguments that they would make, and I'm very sensitive to this because it can be a very valid argument, and that is that in an area where you got a rather fragile infrastructure in terms of provider networks down there, putting managed care into that could potentially compromise that network, force physicians out of those particular areas because they know they're not going to get the same reimbursement rates that they get in other areas, and potentially really handicap the safety net down there. That's always worth looking at, and it's always worth getting data that will either support or basically dissolve that particular argument out there. We had heard that over and over for many years, and so we had gotten to a point where we were comfortable that the safety net would not be compromised, and we were able to do that. The other thing that comes up commonly is just, will people have access to care? And by all means, you can't compromise access to care out there. And people will make arguments that managed care is really intended to deny care. If that's what happens, then you're really in trouble with going forward with something like this. We haven't seen that. We have seen more prudent use of care, which is exactly what you're intended to achieve with this. But those are probably the two biggest arguments: the network, the provider network, and then the access to care.
Okay. Several of you touched on the idea of savings from managed care. I guess I wonder if you could give some advice to folks as to whether legislatively or now post-legislatively, what kinds of data or questions should policy makers be asking of either their Medicaid agencies or the MCO organizations, so that at some point at the end of the day, we do have some evidence of cost savings?
Well, we estimated it in our Senate Bill 7 by just expanding it throughout the state that would save us about $415 million over the 2-year period here. You're going to get a bang for the buck initially when you do it, because the managed care organizations are going to go out there, they're going to create their network, they're going to negotiate levels that are frankly at some savings to them, and which allows them to have something in the range of a 3 to 4% profit margin. And in fact, if they have more than that, they have to basically refund that to the state. And so there's a ceiling on how much these organizations can make coming out of here. We know that the long-term savings is really meant in how you manage the care of these individuals. And so long-term, we can say year over year we're seeing improvements in that area without compromising the care. The fine line you walk, though, is being sure that you don't restrict access to care restrict some accesses to your formulary and things like that, such that people go without appropriate treatment.
We have a question from West Virginia that gets at a comment, one of your answers about what some of the barriers were to passing Senate Bill 7, and it very specifically says, how do you ensure that patients get quality care versus less care? In other words, I think this caller is looking for what kinds of outcomes or measures should we be looking for and putting into contracts as we go through with managed care. And any of you can answer that question.
This is Kathy. I think the state's the state of the art in that is evolving from year to year. And if you look at the more recent procurements, they build in more requirements around quality of care. They do more quality monitoring and more oversight of what we call HEDIS measures, which measure some preventive and other types of quality of care. So clearly you can build those kind of things. All states actually with MCOs build those types of things into their MCO contracts, as well as consumer satisfaction surveys and other. So there's a myriad of ways, I guess, to try to get at that question of trying to get that feedback about whether services are being delivered. And the other important thing I think that states you cannot underestimate the importance of is encounter data, and that is that even when the state is paying a capitation rate to a managed care organization, an all-inclusive rate, they still require the plans to submit encounter data for what encounters, what medical visits and hospital stays did their enrollees have, and that encounter data is critical. Having complete and accurate encounter data submitted by the plans is critical for rate setting, very important in how you even set rates, and how, for the previous question about how do you tell whether you're saving money or not, you need to have complete and accurate encounter data. And then that encounter data also can be useful for other purposes too. So I would say more mature states with more mature managed care programs would probably reiterate the importance of making sure your systems for collecting it and validating it and using it appropriately be addressed.
Okay, let's see if I can get. Go on.
I'm sorry. Just saying that I had some examples of performance measures in my slides, and I also just sent you via email a report that we published earlier this year that has a more complete description, both of suggested performance measures as well as questions that state legislators or other policymakers might want to ask potential bidders around some of these areas. So that might be helpful as well.
We'll be sure and post that when we post the slides from the webinar. Thank you very much. For Kathy and anyone else as well, what role do you see ACOs having in Medicaid in the future?
Well, there are some states that are interested in exploring, who reported interest in exploring that kind of delivery system option. And I think, I'm not the ACO expert, but that would be, like a different flavor of managed care than the capitated managed care kind. So I guess it remains to be seen how those will begin to take shape. But I know in some states, we did ask that question, and there were some states who are interested in giving that opportunity. But I couldn't tell you how many today.
Okay. And then for Representative John Zerwaz, how much of an obstacle to Medicaid managed care expansion was the upper payment limit? This is obviously somebody who knows something about Texas. And are you satisfied with the waiver recently approved by CMS?
The great question. It's something that I lived and continue to live, as a matter of fact. The upper payment limit is a very substantial chunk of change to hospitals in Texas, and for many hospitals, it's the difference in being in the red versus the black. And so it's a revenue stream that we wanted to be sure we could continue to tap into, even though wanted the waiver to go to get into Medicaid managed care across the state. In fact, we did obtain the waiver. It was much slower in coming than any of us had anticipated, and I think that created a lot of concern and consternation for people who are highly dependent on this, and I'm very sensitive to that, and that was something that we put into place, is that if we could not maintain our UPL funding by doing this statewide Medicaid managed care, we wouldn't do the statewide Medicaid managed care. It was that important to us. So we were successful in getting the waiver, and in fact what it does is it creates health care regions is what happens with this, and we'll be able to draw down, in fact, more federal funding as a result of that. But there will be requirements on how we spend that money in order to improve the health of the various regions that are out there. And so we have the approval. I know that was a big sigh of relief for many people out there, and I share that. And we're going forward in terms of better defining what the different regions are doing to improve health care to their citizens.